Hello all, I'm Dr. SJK from ADRPLEXUS. So this is ENT recall from May INI-CET session. I hope most of you would have done INI-CET in a great way because many questions are from basic subjects and it was many questions as per the dictum, as per the guidelines, as per the PVQs. ENT is no exception for that. So we as ENT faculties are stressing too much upon this fact. So ENT is regularly being considered as a subject with 5+ questions. Okay, previously they used to ask only 3 or 2 questions from ENT paper and all, but nowadays we could see at least 6 questions. Even this INI-CET I could say 7 questions. So one question was from about olfaction, so I leave it that to anatomy. So if we add upon that now, it could go till 7 questions. So now we are having 6 questions to be discussed. Okay. Now, what is the trend and how the trend being followed in this INI-CET? So last 2 or 3 INI-CETs, more questions were asked from nose. Okay. But traditionally seen, ear is the bulk subject for a undergraduate. If we ask 6 questions now, usually some 3 years back, it will be 3 questions from ear, rest 3 from nose and throat. Last 2 years, it was not followed. Many questions were asked from nose. Okay. But this, they went back to the basic, went back to the previous trend of asking more questions from ear. So this exam, they asked 3 questions from ear and rest 3 questions from nose and throat. Okay. So as told, if you want to touch a subject for an exam, you should never leave ear. Ear is the most important subject in ENT. So you should know all the nuances in ear, then nose, then throat. Okay. Now we'll start with the question, which is an easy question. A 42 years female is the history of vertigo while lying down on bed in early morning. So usually on getting up from the bed after sleeping or during early morning, it all indicates a positional trigger. A positional trigger of vertigo is always a case of benign paroxysmal positional vertigo. So what about the other options? So Meniere's disease will be having TVS. There should be tinnitus plus vertigo plus fluctuating SNHL. SNHL means sensory neural hearing. All right. Vestibular migraine, headache plus vertigo, which is periodical. Labyrinthitis, vertigo plus fever. Okay. So these are the explanations for the other options. Now, when you look upon this, BPPV is the best answer. So what about BPPV? Benign. It is a benign disease. It's never a very problematic disease. It creates some problems, but it is not very severe. It's a benign disease. Paroxysmal, repeated attacks. Positional, on certain head position. So what are the pathogenesis for BPPV? So if you're having a trickle like this, we are having semicircular canal like this. Now, this semicircular canals can act as 2 mechanisms. One is canal lithiasis, next one is cupulolithiasis. Now, there is a particle called otoconia, which can drift from a trickle into the basal portions of the semicircular canal. As the posterior semicircular canal is aligned with the gravity, so it is more prone for posterior canal BPPV because otoconia has more propensity for reaching the posterior canal than the other canals. So if it reaches over here, that is called canalolithiasis. Sometimes a gel viscous material called cupula, which is found over the semicircular canal, is called cupula. This otoconia will get clumped to the cupula. Clumping of the otoconia crystal to the cupula of the semicircular canal is called as cupulolithiasis. These are two hypotheses for defining BPPV. So maneuvers, diagnostic maneuver is Dix-Hallpike. Treatment maneuver is please. Okay. So what are the other maneuvers? What are the other types of BPPV? We are having two types of BPPV. One is lateral canal, for which Lempert maneuver, barbecue maneuver, log roll maneuver can all be the maneuvers. Another type called superior or anterior canal BPPV, for which Iacoviano maneuver can be the maneuver. So these are the different maneuvers for different types of BPPV. Okay. So the next question is from cochlear implant, which is a gold standard topic. So neurootology, which includes audiogram, then tuning fork test, then OAE, BERA, cochlear implant. So all these neurootology are gold standard for INI-CET. We have told that number of times. So here cochlear implant as asked. So cochlear implant is indicated. Some are saying it is indicated. Some are saying that it is not indicated. So moreover, the options are ototoxicity, otosclerosis, cochlear hearing loss. Some are saying ESCT, some are saying malleus fixation. Okay. Some are saying like this. So whatever it is, if it is a conductive hearing loss, cochlear implant is contraindicated. If it is a sensory hearing loss, cochlear implant is indicated. So what are the sensory hearing loss in this? Ototoxicity can be a sensory hearing loss. A cochlear hearing loss can be a sensory hearing loss. This is a conductive hearing loss. This is a conductive hearing loss. Again, malleus fixation is a conductive hearing loss. So these are all the conductive hearing loss for those which cochlear implant is not indicated. So cochlear implant is indicated in A and C. That is the answer. So ototoxicity, why? See here, if we are having inner ear, okay, so which we are having cochlea, from which we are having a cochlear nerve. So if there is some problem over the hair cells, like in case of ototoxicity, like in case of noise-induced hearing loss, like in case of congenital deafness such as Mondin's dysplasia, okay. So in these conditions, the hair cells are affected. If the hair cells are affected, the nerve is still intact. So you could place an electrode into the inner ear and make contact with the cochlear nerve. In this way, we could rectify the hair cell loss. But we can't rectify a cochlear nerve loss. We can't rectify a cochlear nucleus loss. If that is the condition, if in case of Michael aplasia or bilateral neurofibromatosis, implant is not possible, we should use brainstem implant. Brainstem implant. All right. So whatever it is indicated, maybe a question or not indicated, but the point is, it is indicated in case of sensory hearing loss, not neural. If it is neural, not, it may be a cochlear nerve, cochlear nucleus, or artery pathway pathology. But sensory hearing loss, where it is hair cells which are getting damaged, that is the only possible indication for cochlear implant. So not the external ear or middle ear cause such as otosclerosis or fixed malleus, not a cochlear nerve or cochlear nucleus pathology. Only a inner ear pathology can be an indication for cochlear implant. That is a take-home point with this particular question. So cochlear implant, it will be having a sound processor, a transmitter like this, then receiver like this, then 12 array of electrodes. There will be 12 array of electrodes inserted into the facial recess approach. Many approaches are there, but most commonly used approach is facial recess approach through the round window into the scala tympani. Okay. So this is the pattern where the cochlear implant electrodes are getting inserted into that. So this is a picture taken from our workbook. Okay. So next question. So a 4-year child developed difficulty in opening of mouth following ear infection and episode of painful tonic spasm. So tonic spasm of upper limb. Okay. Fine. So this is the case, tetany. So ear infection is receding. So tetany is ruled out. Okay. Tetany is muscle, tonic spasm of muscle, but it may be due to higher calcium levels, some systemic disorder, not due to an ear infection. So meningitis, you could consider meningitis. Yes, there will be fever, neck rigidity, Brudzinski sign positive, Kernick sign positive. But initial episode of meningitis, you can't straight away go for a focal neurological deficit. Basalt abscess, we should first, following mastitis, there will be a prominence over the sternocleidomastoid. Sternocleidomastoid. But this has nothing to do with the brain focal neurological deficit. So basalt abscess is a localized abscess where the mastitis leads or spreads into the sternocleidomastoid. So this is comfortably ruled out. The choice is between meningitis and sigmoid sinus thrombosis or lateral sinus thrombosis. Both are same. So let's analyze sigmoid sinus thrombosis or lateral sinus thrombophlebitis. So in lateral sinus thrombophlebitis, due to bone erosion caused by the CSOM, there will be thrombus inside the sigmoid sinus that will cause picket fence fever. Okay, periodical release of emboli causing periodical fever spikes, picket fence fever. Okay, then Greisinger sign positive. So thrombosis of mastoid emissary vein is Greisinger sign positive. Then raised, there will be few tests done to measure the pressure compression over the jugular vein, which are Tobey-Eye test. On doing lumbar puncture, if there is raised pressure measure, it is Tobey-Eye test. There is engorgement of retinal veins on pressure compression, it is called Krobeck test. Then on doing a contrast enhanced CT brain, CT temporal, one will see in MT delta sign. MT delta sign. Can you see over here? So this is the area where there will be absence of contrast uptake by the thrombus segment, that is called MT delta sign. So these are the features of lateral sinus thrombophlebitis. Now getting back to the question, a lateral sinus thrombophlebitis, the thrombus can extend into the venous supply, can extend into the arterial supply also, can cause a focal neurological deficit. As we are talking about a thrombus can lead to any number of complications. But meningitis is just inflammation of the meninges. There is no concrete evidence there is some thrombus causing obstruction over the circle of Willis. So if there is some obstruction over the circle of Willis supply only, we could think of a focal neurological deficit. Okay, that is the most common pathological or pathogenesis for a stroke. So if you think of a painful tonic spasm, which could be a seizure, which could be a initial symptom of a stroke or some focal neurological deficit, it could be sigmoid sinus thrombosis. Meningitis, there is no point of neck rigidity or Brody sign positive, Kernick sign positive, nothing was there. Okay, so in question, they clear cut given as ear infection giving rise to a painful tonic spasm, which I discussed with a lot of students. So they have said the same. So painful tonic spasm, so difficulty in opening mouth and painful tonic spasm, which could be an initiative focal neurological deficit following a sigmoid sinus thrombosis or lateral sinus thrombophlebitis. Is that clear? Next question, very gold standard topic in nasopharynx. They will definitely ask one question from nasopharynx, either from adenoid, either from JNA, either from CNS. This time they have asked from JNA, juvenile nasopharyngeal angiography. The question was also very easy. A male patient found to have diagnosed with juvenile nasopharyngeal angiography. Which of the following is not a feature? Epistax will be there, yes. Nasal obstruction will be there, yes. Young adolescent age, yes. Biopsy is not the best investigation. As it is a vascular mass, biopsy is contraindicated. So clinical presentation, young adolescent males with profuse epistaxis, a nasal obstruction causing hyponasal voice, or rhinolalia clausa, frog face deformity, and then the commonest site is sphenopalatine foramen. The hormone that is thought to play a role in JNA is testosterone. Okay. So, and also there will be a sign called Holman-Miller sign. When we push the posterior wall of the maxilla due to the tumor occupying the pterygopalatine fossa, it is called Holman-Miller sign. So, Holman-Miller sign can be due. The treatment can be endoscopic or external excision. So, radiotherapy is usually not indicated in JNA because it is a benign tumor. There could be some cases where there is intracranial spread where you can't do surgical excision completely. In that cases, you could try a radiotherapy. But the best treatment of choice is surgical excision. If it is a small mass, you try it with the endoscope. If it's a big mass, you should go for an extensive external approaches. Okay. So they've asked even in NEET-24 also, JNA is a very, 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 very important topic. So next question, they are frequently asking nerve supply concerning with larynx or from the ear. So in one exam, they are asking from pinna nerve supply or extracortical nerve supply. Next exam, they are asking nerve supply of larynx. So first, what is the question? 45 male with complaints of foreign body sensation of throat following fishbone ingestion. Okay. So there appears to be inflammation over the pyriform fossa. What is the sensory innervation of pyriform fossa? See here, there are options of glossopharyngeal nerve, internal branch of superior laryngeal nerve, external branch of superior laryngeal nerve, recurrent laryngeal nerve. First, what are these nerves? The vagus nerve is a 10th cranial nerve. It comes out of jugular foramen. So, see here in this picture, this one is the superior laryngeal nerve. It is given off at the level of origin itself. So superior laryngeal nerve is given off at the level of origin itself. So after given off at the level of neck, the superior laryngeal nerve is divided into two branches. Internal branch is going inside, external branch is coming outside. So the internal branch basically supplies the sensory supply. The external branch is a motor supply, which is supplying cricothyroid. The recurrent laryngeal nerve is a nerve which is given off at the level of thorax. So once the pink shade given here is the recurrent laryngeal nerve. It's given off at the level of thorax. It is ascending upwards into the neck. That is the stupidity with recurrent laryngeal nerve. It is not given off at the level of neck. It is given off at the level of aorta. So once it is given off at the level of aorta on the left side and subclavian artery at the right side, these nerves recurs into the neck. Okay, so superior laryngeal nerve, okay, which is given off an internal branch, is supplying mucosa of larynx above vocal cord level. So recurrent laryngeal nerve, mucosa below vocal cord level. Motor supply, cricothyroid, and then apart from cricothyroid, all muscles of larynx are supplied by recurrent laryngeal nerve. This you know very well. But what about pyriform fossa? Now, where the pyriform fossa lies? See, this is the if this is the ideal picture, now this is the area of pyriform fossa. It will be starting above the level of vocal cord itself. Okay, it will be starting above the level of vocal cord itself. Okay, so that could be one pointer towards our answer. The next pointer is the internal branch of the superior laryngeal nerve and the recurrent laryngeal nerve both will meet at the apex of the pyriform fossa at an anastomosis called Gallen's anastomosis. What is Gallen's anastomosis? Meeting between two sensory branches, these two. Okay, so mucosa, which is supplying above the level of vocal cord, which is internal branch of superior laryngeal, and then a branch from the recurrent laryngeal. So both will meet at the pyriform fossa only. Now, it is mainly supplied by this internal branch of superior laryngeal nerve. This is the answer for this question. Internal branch of superior laryngeal nerve. So, in other words, if this question is asked clinically, if you want to take a pyriform fossa biopsy, what is the nerve block that you will give? The nerve block that we will give is, we should have hyoid bone as the pointer. Okay. So medial 2/3, lateral 1/3, we should touch the hyoid bone. We should introduce our needle in the lower direction and reach this particular area. This is the nerve block, superior laryngeal nerve block or internal branch of superior laryngeal nerve block given for pyriform fossa biopsy. The pyriform fossa is mainly supplied by internal branch of superior laryngeal nerve, that too from Gallen's anastomosis. These are the important points that you should make it very clear. They may ask any question in the future. Okay, so the answer is internal branch of superior laryngeal nerve. Next question. Which of the following can be a cause of stridor in an infant? So options are laryngomalacia, hemangiomatous polyp, recurrent respiratory papilloma, subglottic stenosis. Okay. So laryngomalacia, as you all know very well, most common cause of neonatal stridor. Okay. Whereas a papilloma can cause stridor, but not at an infant. Hemangiomatous polyp, not at the infant. Subglottic stenosis can cause a stridor in case of an infant. The answer is A and T. Okay. Now, a question, picture taken from our workbook. So, if it is block is above the level of glottis, it is inspiratory stridor. What are the reasons? Some epiglottis cyst, supraglottic tumor. These are the reasons for inspiratory stridor. At the level of glottis, like vocal cord palsy, subglottic stenosis, these all can cause both inspiratory and expiratory stridor. So below the level of glottis, if there is some problem over the trachea, so tracheomalacia, so some problem like that, now you will have expiratory stridor. So this is taken from our workbook. So we totally got 6 questions from ENT in this INI-CET. All these 6 questions are in our workbook. All have been covered by our faculty. So our ADRPLEXUS motive is workbook-based teaching. We will be giving a concise material that you could revise on and on and on. You don't have to rely upon any outside material. So we had this workbook. All these 6 questions of ENT are from our workbook. So that's how ADRPLEXUS works. That's how things work in a way. So I hope you have done ENT part very well, because the questions were not so tough. It was easy. So if you have read our workbook in a good way, so you would have answered most of the questions. So with that note, I'm signing off. Thank you. So please don't sign off from reading, because we'll be having NEET in another 1 month. So please stick to your plans, stick to your schedules. Keep reading, and best of wishes.